Good day, everyone, and welcome to today's webinar, State Palliative Care Policies and Emerging Innovations. Before we get started, we'd like to review a few technical items to make sure that you can interact with us today. For the Q&A, please click the Q&A button and a window will appear where you may submit a question. We'll take questions at the end of today's webinar. We're recording today's session. However, participants' lines are muted, so no need to worry about the recording capturing your interaction. We'll provide access to the recording on NASHP's website for you to view and share the recording, as well as the slides after today's event. Thank you for joining us today for this webinar. My name is Salom Teshale, and I'm a Senior Policy Associate here at NASHP. I want to thank the John A. Hartford Foundation for their very generous support of and their guidance with NASHP's Palliative Care Resource Hub. And I want to thank Scott Bane, our project officer. On our agenda for today's webinar, we'll hear first from Scott Bane, Program Officer at the John A. Hartford Foundation. Then we'll have presentations from Allison Silvers, Chief Healthcare Transformation Officer at the Center to Advance Palliative Care, and Judy Mohr Peterson, MedQuest Administrator at the Department of Human Services in the state of Hawaii. I'll also share information about NASHP's work tracking state palliative care policy. Finally, we'll conclude with a Q&A with our presenters. With that, I'll pass it over to Scott to take it away. Thank you.
Thank you so much, Salom. I'm Scott Bane. I am a program officer at the John A. Hartford Foundation. We are a proud funder of NASHP and the Center to Advance Palliative Care, and we are very pleased to sponsor today's event focused on state palliative care policies and innovations. The John A. Hartford Foundation is a national philanthropy based in New York City. Our mission is to improve care for older adults. And we do that in three priority areas: building age-friendly health systems, supporting family caregivers, and improving serious illness and end-of-life care. On behalf of my colleagues at the Foundation, I want to thank NASHP, CAPC, our guest star from Hawaii, but most importantly, everyone in the audience for joining today. Your interest in how state policies can support access to palliative care is exciting to see. Today's session is part of a grant from the John A. Hartford Foundation that supports NASHP in convening and engaging state leaders to improve care for people with serious illness. NASHP is partnering with grantees like CAPC that also provide amazing resources, such as the Spotlight on Home-Based Palliative Care you'll hear about today. I will leave you with one other free resource that I hope you'll use. It's the Serious Illness Messaging Toolkit, which can help professionals like yourselves talk to the public as well as fellow policymakers about effective ways to talk about palliative care, advanced care planning, hospice, and living well with serious illness. Go to seriousillnessmessaging.org to use this new resource. We hope you will take advantage of and spread the word about all the resources and tools that NASHP, CAPC, and our other grantees are producing to help every state ensure age-friendly care for older adults with serious illness. Get these latest resources by subscribing to johnahartford.org. I look forward to our discussion today, and I will now pass the baton to Allison Silvers from CAPC to get us started. Thank you.
Thank you, Scott. I'm really excited to be speaking with you today. From the Center to Advance Palliative Care, we collect all sorts of information about what's going on with specialty palliative care programs, what are the best practices, what are the additional needs, and we also collect information about tactics and strategies and skills that the healthcare system as a whole can use to improve care for people with serious illness. Earlier this year, we released, as Scott had said, the Spotlight on Home-Based Care, which I'm going to present some of what I think are the more interesting findings, particularly from a policy standpoint. I do want to, before I start, I do just want to give a caution. The information I'm about to present is based on self-report. As you know, there's no licensure currently or any required certification for specialty palliative care services. So we have no way of knowing if the people that respond to our surveys and registries are a representative sample of what's out there. We have partnered with the Palliative Care Quality Collaborative, who continues to collect really detailed information on palliative care programs, both inpatient and in community settings. And they also, in addition to just collecting the information, they work with their members to make improvements. So I put the link to the Spotlight here, and again, it's free and open, so I encourage you to use it. Next slide. So I'm going to start with the good news, which is that in today's era of healthcare, most large hospitals in the United States do have specialty palliative care services. As you can see from the map, we used to grade states based on how available specialty palliative care was in their hospitals. The last time we did this was 2019, and you can see just the color variation. In addition to the geography, the other areas where there's opportunity to improve access to palliative care, inpatient palliative care, is for-profit hospitals lag behind their nonprofit counterparts. Public hospitals, for likely reasons of resource constraints, and rural hospitals are definitely lagging behind. Soul community at 40% and rural only at 17%. However, if you look at patient admissions, so patients on the whole tend to use the larger hospitals. So roughly 92% of all hospital admissions are admitted to a hospital to provide palliative care. Next slide, please. So when you look at palliative care in the community, it's a similar story. Most urban locations have access, or at least availability, of a home-based palliative care program, but that jumps down to 39% for rural counties. Geography matters. We are doing research now. I think payer mix matters as well, which Judy probably knows only too well. So while these are national statistics, the inequities are certainly apparent from the graphs as well. Next slide, please. So based on what we've been able to collect for home-based palliative care, 41% of those home-based programs are operated by hospices, with another 7% operated by home health agencies. So definitely hospice is the preponderance of who's delivering home-based palliative care, but they aren't the majority. Back to that grading of the states, specialty palliative care services grew up in hospitals, and a lot of those hospital-based programs are in a great position to deliver care to patients when they're in crisis, hopefully stabilize them and clarify goals during the admission, and then continue to make sure that the train stays on the rails after discharge. So I guess I just wanted to remind folks that there are a variety of administrative homes for home-based palliative care. Next slide, please. So when we look at the patients being served by home-based palliative care, Yes, cancer is definitely the most common illness, which is again, back to the inpatient roots of palliative care, it's also the most well-established relationship in acute care settings. However, 20% of all patients are in cardiovascular services, often heart failure, dementia is also quite common, COPD, and so on and so forth. There really is a great variety of needs, and the way that this works well is that the treating clinicians are either leading the care or co-managing the care with palliative care, and palliative care either consults or co-manages. Next slide, please. So length of service. I think this is a very interesting topic, and I'm hoping I could add some information from this for your consideration. I know that there's very strong interest in ongoing monthly enrollment, monthly payment, and ongoing services. But I will just ask you to note in the data that some patients don't need that. On average, patients remain on home-based palliative care, again, according to the self-reported information we collected, just over 4 months. And then what I find very interesting is more than a third of patients are on the service for under 3 months. We also looked at discharge disposition, and I didn't make a slide here, but I did note 31% of patients are discharged to hospice and 7% die. But if you put all these statistics together, there's a pattern of patients who benefit from home-based palliative care and then are either stabilized and no longer need the services, or stop the services themselves because there's lots going on in their life and lots of needs. And once their symptoms are under control and their family and clinician communication has been clarified, they feel more stable and could take care of, manage their illnesses on their own going forward. However, yes, there are still, as you can see, there's 9% that stay on the program for more than a year. There still are a good number discharged to hospice. So it's a variety of patients being served. And I guess I'll get on a soapbox for a second and say, I would encourage you to just think about how you can serve that variety, both the ones who need a short-term intervention as well as long-term ongoing support. Next slide. 24/7 availability of the clinical team. Right now, we're about half of all home-based programs that are providing 24/7. It's actually, I think it's 47%. And then another 5% do provide some evening and weekend coverage. So if you look at it, about half and half. Again, back to the role that home-based palliative care plays, if it's a consultative role, it might not be as necessary to have 24/7. If it's a co-management role, it absolutely should, and there should always be a plan for crises that happen off hours. But there might be opportunities to improve availability of 24/7 response if patients' health homes or their patient-centered medical home or their care management service, or perhaps if they're in long-term services and supports that have 24/7 call availability. There might be ways to collaborate and make sure that patients and families' needs are met 24/7. So just when you look at the half, it might not be leaving half of patients without an option. Next slide, please. staffing. I think this is another topic of high interest. And it should be of high interest because there's still a lot of variation. So out of the programs that we collected information on in this data was collected in 2022, the preponderance of programs did have a very multidisciplinary team, chaplain for spiritual care, nursing, social work, medical, advanced practice. But then as you see, as you go to the right of the slide, there are also a lot of programs that are doing a mix of these professionals. In addition to the ones named here, there are also programs that have other staff that they deploy, sometimes more commonly LPNs, pharmacy, nursing aides. And on the note of nursing aides, will say when CAPC investigates patient needs, what often floats to the top is personal care services. That when that isn't available, the medical care is appreciated, but there's a desperation for some relief, caregiver respite, and some support of what can be very heavy personal care requirements. There's a new Medicare model that's coming out for people with dementia called the guide model. And that actually does include, it'll be the first time to my knowledge that Medicare is paying for caregiver support. There are a few palliative care teams out there that are also trying to meet that need. Next slide. So again, I'd encourage you to read our full spotlight because in addition to all these fun facts and stats, we pulled together our recommendations for what best practice home-based palliative care should have and should do. This is a screenshot. There's more to it, but interdisciplinary, at least 3 disciplines on the team. Probably most important, having the specific competencies that are needed in palliative care, with the ideal being specialty certification. We do recommend 24/7 access to a clinician who can manage pain and symptoms and has access to the medical record. Again, how that gets executed, there's some opportunity and variety there, and then assess across all potential needs and burdens, and then of course make sure that you've got capability to address it. The full list of recommendations is in the report. So that in a nutshell is the state of palliative care as far as we know it. I'll turn it over to Salom now.
Great. Thank you so much, Allison. Next, I'll be sharing with everyone highlights on recent state activity supporting palliative care policy, featuring some of the products that we've developed here at NASHP. Next slide, please. To give a bit of background about our organization, the National Academy for State Health Policy's vision is to improve health and well-being of all people across every state. The mission is to be of, by, and for all states by providing nonpartisan support for the development of policies that promote and sustain healthy people and communities, advance high quality and affordable healthcare, and address health equity. NASHP provides a unique forum for the productive exchange of strategies across state government, including the executive and legislative branches. Next slide, please. Today, I'll be sharing with you information about state activity in palliative care policy. Here at NASHP, we've developed an extensive palliative care resource hub with blogs, briefs, and other resources, including 3 palliative care policy tracker maps. States have conducted a range of activities in advancing palliative care policy, and I'll highlight information around these 3 activities listed here: budgets and legislation, task forces, work groups, and advisory councils, and palliative care education campaigns. I'll also share information from our new fact sheet here at NASHP on how states can incorporate palliative care services into already existing initiatives. Next slide, please. We track state activity on palliative care in legislation and budgets, and most recently updated our budget and legislation tracker this July, finding activity in 13 states in 2022 and 2023. States indicated activity related to palliative care policy topics such as funding for palliative care services, definitions of palliative care, coverage requirements, and palliative care educational activity. For example, Indiana's House Bill 1457, now Public Law 147, expanded the definition of home health services to include community-based palliative care. In Indiana, community-based palliative care is defined as, quote, patient-centered and family-focused palliative care that's provided in a location that the patient considers to be the patient's home, end quote. Virginia's fiscal year 2023 and 2024 budget includes funds for the Medical College of Virginia Palliative Care Partnership and for contract to expand pediatric hospice and palliative care services. Illinois passed legislation requiring health plans to provide coverage for community-based pediatric palliative and hospice care starting January 1st, 2024. New York also passed legislation designating November as Hospice and Palliative Care Awareness Month. That's just a small sample of some of the recent palliative care policy activity that states have been conducting via legislation and budgets. You can check out more on our website at nashp.org. Next slide, please. NASHP also tracks state legislated palliative care task force activity. More than a dozen states have legislation around a palliative care task force, work group, or advisory council. The councils are legislatively mandated and often provide recommendations to the legislature on palliative care related topics. NASHP's Palliative Care Task Force Tracker examines what states pass legislation establishing a palliative care work group, council, or task force. The tracker's accompanying chart includes legislative establishment and any recommendations, reports, or websites that the group has created. Today, I'll briefly highlight as an example of work group activities, Maryland's recent activity. Maryland's House Bill 378, now codified as Chapter 301 in the Acts of 2022, directed the Maryland Healthcare Commission to convene a work group to study palliative care services and make recommendations to improve palliative care services, with a specific set of requirements on topics to review. The work group released their interim report in July. The work group reported on the state of palliative care in Maryland, noting data from a CAPC report that most large hospitals in the state had palliative care services, but a lower percentage of smaller hospitals did due to resource challenges. Emerging themes from the work group's interim report included the need for increasing awareness about palliative care and the difference between hospice and palliative care, addressing service gaps, expanding access to palliative care from hospitals, partnering with the state's advisory council on quality care at the end of life, engaging stakeholders, exploring workforce and funding models, and data collection. The interim report also noted an overview of federal palliative care legislation, including introduced bills between 2020 and 2023. This work group is next scheduled to develop recommendations in a final report to their state legislature to address identified challenges and needs for palliative care in the state. Next slide, please. States can also use their websites to educate the public on palliative care and the state's activity in that space. NASHP's Palliative Care Information Program Tracker examines state-developed palliative information programs hosted on their website. These websites can include definitions of palliative care, links and resources for providers, patients, and others about palliative care in the state, or educational videos about palliative care developed by the state. Examples of information that legislation has required include information on continuing education, resources and materials, or best practices. For example, the state of Texas's webpage includes definitions of palliative and hospice care, caregiver-targeted resources, information on how palliative care is often paid for, information on advanced care planning, who can benefit from palliative care, and a link to an educational video on palliative care. Texas also recently passed legislation designating October 10th the Supportive Palliative Care Awareness Day. Next slide, please. In addition to developing educational campaigns, work groups, and legislation, states have also approached incorporating elements of palliative care into their state's current initiatives. This new fact sheet from NASHP, How States Can Embed Palliative Care in Healthcare Reform Initiatives, highlights examples of states incorporating palliative care services through methods including, but not limited to, 1915C home and community-based services waivers, patient-centered medical homes, managed care, and health homes. For example, California included in their 2022 Enhanced Care Management Policy Guide the need for palliative care as part of a comprehensive health assessment. Recently, California's 2024 DSNP Policy Guide also included care coordination requirements for DSNPs on the provision of palliative care services, including guidance on eligibility, on providers and settings, and on services. Next slide, please. This is just a small sample of the range of recent palliative care policy activity that states are conducting. We also recently kicked off our 2-year NASHP Serious Illness Institute, where 6 states are working to advance policy in their work around a Medicaid palliative care benefit within their state. These participating states are Colorado, Maryland, Maine, Ohio, Texas, and Washington. For information about national state activity and for more resources to support state policymakers interested in palliative care policy, please check out our website at nashp.org/palliative care. Thank you, and I will now hand it over to Administrator Judy Mohr Peterson to share information about the state of Hawaii's work.
Thank you so much. I appreciate that. Hello, everyone. I'm Judy Mohr Peterson, as was noted. I'm the MedQuest administrator, is actually the Medicaid director for the state of Hawaii. So I was wondering if we could actually, I know that I don't have any slides that I'm going to be sharing, but I was wondering if you could just go back a couple of slides that show their various different initiatives. Forward, no, not that far. So that one. Can you just hold there for just a moment? Because most of those, if not all of them, are Medicaid related, and they're illustrative as to why it is that Hawaii is going down a different pathway and trying to forge a pathway to provide regular Medicaid coverage for community or home-based palliative care. So we're trying not to go down a waiver method. We're trying to, even though we could, we're trying not to have this limited to Medicaid managed care, even though we could, because we're a managed care state, but not all states are. We are trying not to use it within the Medicaid managed care LTSS services. We have DSNPs, but we don't want to go down that direction. And then the health homes or patient-centered medical homes, which use the same, a similar type of authority, all of those require, each and every one of those requires a particular application for a waiver, a particular type of operating your program. You have to have managed care, or you have to have Medicaid managed care, LTSS services. And instead of pursuing that, what we're trying to do is forge the pathway with CMS to have palliative care or home-based palliative care defined as a regular Medicaid benefit, just like we would for any other kind of Medicaid service. So that's what I wanted to talk a little bit about today. So thank you very much for sharing that slide. That was very helpful. So I just wanted to cover today some of the pathways that we have considered, and why it is that we've gone down the direction that we have, and the sort of where we are, as to where we are right now. So with some of the things that were not incorporated there were the concept or the idea of hospice. And I think all of you know, but just as a quick reminder as to why it is that we're going down the pathway of a regular Medicaid state plan, what Medicaid programs call the state plan benefit, and not hospice, not using hospice for that. And it's largely because of the limitations on the use of curative care, as well as the requirement to have a diagnosis of or a prognosis of less than 6 months to live. And so it leaves this gap where, someone is struggling, or a family is struggling with someone with a really serious illness. They're not at that place yet where they're still considering curative options. They still want to receive curative care. And there's still the possibility for recovery, but yet the serious illness that they have is a high likelihood of mortality or decline over time, et cetera. But they're not there yet. They're not at that place. And yet they still need all this support, all this wraparound supports, et cetera. So hospice, despite the benefits for the kind of benefit that it provides, particularly hospice allows you to incorporate into the team some other types of providers, like a spiritual, I was going to say spiritual guide, but that sounded, I'm not sure that that's the right word, but hopefully you understand who that is, social workers, et cetera, as part of that. We're providing the personal care services. So it's a broader group of individuals who are allowed to be part of that hospice team. But yet, if you use the hospice benefit, there's severe limitations on who can receive that care, and for how long. So that we put that aside, and we, in our conversations with CMS, of which there have been many hours and hours and hours of discussions with CMS, we talk through why not hospice. Another form that that hasn't been brought up yet in a different forum is home health, not health homes, but home health. The going in, and there is the possibility you can use that, but a couple of the terms that limitations around home health is why we didn't go down that pathway, is that it's by definition it's intermittent care, and what we're looking for is long-term care, extensive long-term care, not intermittent. And then also there is an expectation that it leads to recovery, that leads to people getting better, and that's actually is not the case for palliative care. You don't have that. You don't include that as one of your things. It's like, oh, we think this person is going to get better, because by definition they're dealing with a serious illness, and it's possible that in response that the treatment or the illness does not get better, and it leads to a decline. In fact, the person may reach a point in which then they do qualify for hospice. There's actually just regular clinical services, like the run-of-the-mill clinical services like we cover for many other types of Medicaid services. There, again, it was the list of providers that wound up being the limitation. Of course, palliative care is provided in the hospital setting, and and it's actually a covered benefit. Palliative care is a covered benefit in Medicaid programs through hospitals, through institutions. But it's a much tougher thing to find a way to cover it within the community. We used community as opposed to home because there wound up being even if we tried to define it broadly and say, well, it's wherever that person is residing, there tended to be a lot of questions about that. So we just said community, and that allowed individuals who were perhaps living in either nursing facility or adult foster home, somewhere like that it was clear that palliative care was meant for them, or this community-based palliative care is meant for them as well. The other thing is that with the eligibility, the criteria, it's we wanted to make sure that it was for individuals with serious illness, not necessarily with a prognosis of 6 months, as I was noting before. So the treatment and the treatment goals, it didn't necessarily have to lead to, it leads to, quality of life goals and not necessarily recovery, like back to total recovery goals. And then it's a broad range and it's a multidisciplinary team. And the other factor that also played a role in the final direction, and I'm leading it as a big surprise as to what authority we are currently engaged with in CMS and pursuing. The final thing that was also proving to be somewhat challenging is actually the payment methodology, because you could go down a fee for service in which you're paying for each and every service, but that just was not going to work for the type of services that we have an expectation would be provided with community-based palliative care. So instead, we are looking for more like the concept of a bundled payment or a per person payment per month that the person is engaged in the palliative care, and it would include the whole team and all the team activities. Okay, so I am actually not going to be talking about implementation. You saw that in some of the other slides that we do have some very active implementation around training, education, around trying to identify teams, et cetera. So we have a lot of efforts going on in there. So our primary effort that I'm talking about today is the authority that we're pursuing to make palliative care, community-based palliative care, be just a regular, like any other kind of Medicaid service. And the category of service that we chose to use in back and forth with a lot of time and effort back and forth with CMS is actually the preventive services model. You might be going, preventive services, how does that fit in there? Most of the time you're thinking about those, and it's making sure that you can get your screenings and well child visits, et cetera. But in talking with CMS, they agreed, and we all agreed, that preventive services can be defined quite broadly, including preventing worst outcomes, et cetera. And palliative care is definitely designed to help the individual and their families lead a better quality of life, approach their care so that they have more coordination and collaboration, et cetera, so that they can help manage the serious illness that's now facing themselves and their families. So preventive services is a method. And the other thing that is actually unique to the area of preventive services is that you can include a broad group of providers that don't necessarily have to be credentialed and licensed like typical Medicaid providers, which does allow us to include a much broader range of providers that would be inclusive within that team-based setting. So that's where we are right now. I know it's taken us I've given this talk multiple times over the past 2 years. And so each time I think, oh, we're going to make it. We're almost there. And then we have another, another thing will happen. Another thing, will happen within our conversations back and forth with CMS. But I have a very persistent team. Great. In fact, I'm going to call them out right now. Joyce Suarez has been fantastic as a lead. Edie Mayashiro as well. They're actually on and listening. So hopefully they're beaming with pride as I am about all the work that they've been doing. We've been working with some consultants as well. So I think that is about it when it covers it. That preventive services allows us the flexibility for the treatment models. It allows us the flexibility for the providers, the payment model that we want to use. And we don't have to define necessarily as strictly as some of those other categories, the eligibility criteria about who would be receiving that particular treatment. And it's a much broader group of treatment that we can provide. So we're excited about that as an opportunity. I don't know whether it will translate into Medicare, because Medicare, is a different beast when it comes to their treatment and their providers and the prevention. They do allow Medicare Advantage, but not traditional Medicare. But we are hoping that it does help us with other states. We're hoping that there could be a model for other states who may not have a managed care program, who might not want to get another waiver for 1915C or, go down that route. That we're hoping that this will be a model that other Medicaid programs might be able to use, and then they can define whatever provider group, et cetera, that they want. And we're, of course, once it is approved, we're always happy to share with NASHP and others. With that, I think I'm going to pause and turn it back. Salom.
Great. Thank you so much, Judy. Now we're at the time of the webinar where we'll open it up to Q&A. Great. So one question we had come in to the Q&A, and also please feel free to enter in all your questions into the Q&A, and we'll get to as many as we can in our remaining time. Right, so one question we had was for Judy, who had mentioned the focus on community, including individuals and nursing homes. This person asked, did you face any issues with the Medicaid HCBS settings rule, or were you able to avoid any issues because it's a state plan benefit?
It is, since it is a state plan benefit, and it just means, what this means is that the services, that palliative care can take place in a broad range of settings, including nursing facilities, including home or community-based settings. So I think, I don't think the settings rule does not conflict with us, the provision of the palliative care, which would be just another team coming in and helping those individuals work through their issues, through their serious illness and their transition to whatever direction they're going. So it's the home and community-based settings rule, since we're not going down a 1915, we're not using a home and community-based pathway. It winds up not being then applicable. We're using a state plan benefit.
Great, thank you. Another question we had come in was, you had articulated many potential benefits. Do you foresee any potential limitations or challenges? I think this one might have been for Judy, but I can also open it up to the group in general.
I would guess that means about the potential benefits of preventive services designation.
So far, we haven't seen, well, one, we're still working with CMS right now. Our latest group of documents, et cetera, are into CMS right now, and they're reviewing them. We don't have any, so far, we haven't identified any negatives on the side of the preventive services, except for perhaps we had to spend, in order to use the preventive services, you actually have to provide pretty detailed explanation of each and every provider type, especially if they're not a typical provider. So it required a lot more work when it came to that. But that's the only negative thus far. And it avoids the other negatives that we were running into with some of the other different various Medicaid authorities that one could use. I don't know if that was the question, but.
Okay, great. Thank you.
Salom, would I be allowed to ask a follow-up to that?
Absolutely.
So back to the preventive service, I'll call it a designation. That idea of length of service and, you know, for example, somebody going into the nursing home to take care of a patient as any other provider, would the preventive service have any caps or need for reassessment? I'm just thinking, again, palliative care is a limited resource, and to make sure it gets to as many people as possible.
Yeah, thank you very much for that question. That gets a little bit to our implementation side of it. We have and we're working with a broad range of community members who've been focused on this, on the provision of palliative care for actually a number of years. And so we've worked very closely with them regarding eligibility criteria when it comes to, okay, which serious illness, how far along, and it's not necessarily how far along, but what are the serious illnesses that we're looking at and considering. We do have an assessment. We do have a reassessment as people are moving along with the progression of their disease, either recover or not. So we are thinking about that. The preventive services benefit itself, we don't have to include that in the state plan information, but we do need to incorporate that into our implementation side of it. So that's how we would characterize this, that there's what you would include for permission in order to get this to be a covered Medicaid benefit, and there you want to be as probably about as broad as you can manage it and still get the program running, so and getting Medicaid payment for it. But then on the implementation side of that's where you would put in those additional criteria for screening, for length of time, and eligibility, et cetera. Hopefully that's helpful.
Great, thank you. We have another question in the chat, and I believe this one is also for you, Judy. Did you consider a 1915I SPA? What did you see as the benefits or drawbacks of this approach?
Thank you very much. We are a state that has, we have all of our, except for one, we have all of our home community-based services and 1915C-like services and 1915I-like services in an 1115 demonstration waiver. So we use our 1115 demonstration waiver as our overarching waiver. And yes, we did look at it, we did think about it, but again, this might sound weird, and we could have used it. We could have gone down a 1115 route, but we were convinced that, like as I started off in the conversation, we wanted to forge the pathway so that states did not have to ask for some kind of special waiver, either an I or a C or an 1115 or health home or this or that. We wanted to forge the path so that this became a regular Medicaid benefit that any state could put in place without needing to seek a waiver. It could become a state plan benefit. There's a lot of advantages to having this be a state plan benefit. You don't have the same kind of reporting requirements, the same kind of limitations and restrictions. And it just creates a much broader opportunity for many more states in order to apply for and get this. So we were convinced that even though we could have gone down the route of either 1915I, 1915Cs, there's many other kind of weird myriad of number jumble letters that one Medicaid program could use. But just given the direction that our state wanted to go as a state to promote palliative care broadly for the broadest group, we decided to take it on to see what we could do to make it be have it be a state plan benefit. So it proved to be like when we first started off, it was like, we got this, we can do this, but it's proven to be much more challenging than what we thought. But we feel like we're very close to finally getting the approval and finally getting through everything to be able to get this it finally approved. It's been a long journey, much harder than what we thought, but that was our ultimate goal. So yes, you could go down an I route, you could go down a C route, but again, that wasn't our goal.
Okay, great. Thank you for that answer. Another question we have within the Q&A is, has there been any focus within the discussion and activity on pediatric palliative care, both community and institution-based? So I can say on NASHP's end, we focus on older adults and people with physical disabilities. So on our end, we have not focused on pediatric palliative care, but I open it up to the others.
We in Hawaii, we've included a pediatric palliative care. We're happy to share with whoever it is that reached out and had that question. We're happy to share what we've done so far in this particular area.
And I'll just add that the data we presented does definitely include organizations that care for pediatrics. In the spotlight, we talk about what percentage care for each type of population, and there's a great deal of overlap. A lot of the providers care for both pediatrics and adults.
Great, thank you. So another question, excuse me, another question in the chat was, can you speak to the benefit of taking an expanded vision, creating state serious illness council with members who represent a broader group of stakeholders? So if I'm interpreting this question correctly, they're asking about the benefits of developing a state palliative care council versus a state palliative care coalition.
I'd like to, if I may, just add a little bit of historical context. The palliative care state councils that were created, the organization that was behind that was the American Cancer Society, and they actually developed model legislation and then worked with their various communities in the various states to have that adopted in each state. So I think the high point was 27 councils. It took quite a lot of effort to get it in. With the states that didn't have it, it probably took even more effort and was not successful. So I'm saying that only because, certainly times are different. I think they started this maybe back in 2015 or 14. So times are definitely different, but it might not be possible to get a formal council in every state.
Thank you for that information, Allison. I would also note too the councils that we highlight within our NASHP trackers are ones that were developed through the passage of state legislation. So our work and our content there is informed by the work that the state has done and the legislation that has been passed there. Okay, great. So we have about 5 minutes left for our Q&A. We have a question that came in. So Judy mentioned under preventative services, the advantage would be to avoid something worse from happening. What examples did she use to convince CMS of this concept?
Well, first, to be fair to CMS, they were the ones to help us come up with that, with the idea of preventive services. Oh gosh, I'm actually, I asked my team to type something to me in my own team chat that I've got going here to help me recall specific examples of what are some of the things that we came up with. I think let's just use an individual with cancer. That's one example I can think of where someone without that coordinated care could be frequently going into the emergency room in the hospital, repeatedly because they're either dealing with pain or they're dealing with medications, etc. So that by providing that palliative care, it helped as a preventive type service. It helped prevent more serious outcomes and more serious illnesses. So avoiding ER visits, avoiding multiple medications, hopping from hospital to hospital, bouncing in and out of care or care homes. So those are all examples that we used, and CMS actually used. They talked with us through the use of preventive services. So CMS is an interesting group to work with in that, we talk to, they're a very large organization and they have lots of different people who are working on lots of different topics. So we wound up having to work with many different parts of CMS. And so part of it was actually CMS talking with CMS about how this can work together, and then talking through what all the first different options, why we thought this was a better option than that option, et cetera. So CMS did not have a uniform understanding about what community palliative care was. Like many, they conflated it with hospice. Sometimes they would conflate it with hospice. Sometimes they would think it was health homes, et cetera. So, or home health. So it was, there was lots of conversations around that.
Great, thank you so much, Judy. Okay, so we have just a couple of minutes left in our Q&A. I think we have time for one more question. Look. Great. Our final question is, have you had any challenges distinguishing the need for specialty palliative care?
Is that to me or to somebody else?
I was going to ask that
I'll leave to the
too.
group.
I will say CAPC, with guidance from NASHP, will hopefully soon be publishing a paper on how non-specialty palliative care could be advanced through state Medicaid, existing benefits, all the ones that Judy mentioned, home health, health home, patient-centered medical home, et cetera. And that the line is, the existing staff with some existing skills in communication and payment symptom management could take care of a lot of the need, but when the issues get complex is when there's the need for specialty palliative care.
Thanks for that, Allison. And I would say, not so far. In a way, we haven't run into that as an issue as far as the specialty palliative care and the need for that idea of there do need to be individuals who have that expertise. But again, yet to be fully implemented, and so we'll see whether that does come up. And the only thing I do want to mention, because I did say that out loud, but coming up with a bundled payment was actually also one of the reasons that we wound up using preventive services. It was not easy to work through those topics as well. It's not typical, and it's not usually how CMS operates with other kinds of clinical services.
Great, thank you so much. We're just at 4:31 Eastern. That concludes our webinar for today. Thank you again to our speakers so much, and to our participants for joining us for today's webinar. As a reminder, please fill out the survey at the end of the webinar. We greatly appreciate your feedback. Thank you so much, and have a great day.